So may I invite Dr. Dinesh Talwar to speak on the management of wet AMD? So speak.
So Dr. Dinesh Talwar, he's one of the leading retina person, not in India, world over, and his work speaks highly for his status in terms of clinical research and patient care wise. He has been with the faculty of RP Center earlier. Now he works for Center for Sight, director in medical and surgical retina services. He's going to talk about wet AMD and what's the new thing in that. We've been listening to wet AMD for so many years. Is there something that changed? Dr. Dinesh.
Yeah. The first thing that's changed in AMD is that we become richer as a country, and as the economic status of a country goes up, the number of patients living longer increases, and so the incidence of age-related macular degeneration also rises. So the epidemic which is afflicting the Western world is soon going to come to our shores too. It's already landed, but it's still not an epidemic. This is my disclaimer. Now, the important thing, so that's why it's important for us to know about exudative macular degeneration. This is not one disease. This is a combination of classic lesions, minimally classic lesions, occult lesions, and not only that, different patients behave differently. We know from the Marina and Anchor study that if you give the injections monthly for 2-3 years, the patients behave very well. We are able to improve vision as opposed to previous studies with other treatments where the vision used to slowly deteriorate. But it's an extremely intensive treatment and is exhausting for both the doctor and the patient. The SUSTAIN study showed us that actually the number of injections needed varies from 3 injections in 20% of patients to another 30 to 40% of patients who need 4 to 5, and some patients who need monthly injections. So there's a need to individualize the treatment. And fortunately for us, today we have many treatments available. Ranibizumab as both biosimilars and the innovator drug, bevacizumab, aflibercept, and finally brolucizumab also. The optimum treatment is one which is efficacious, safe, easy to use, and has maximum intervals between treatments. But remember, the most important thing for us is safety, not efficacy, because ultimately you want to remain safe, both you and your patient. The factors that affect visual outcomes include intraretinal fluid, subretinal fluid, and sub-RPE fluid. This is a study which showed, this was a post-hoc analysis of the VIEW trial, which showed that patients who had more intraretinal fluid had lesser improvement in visual acuity over a longer period. The other important thing is that patients in whom the fluid goes away and then comes back soon, these patients don't behave as well. Whereas if you can prevent the fluid from coming back for a longer time, the patients do much better. So patients in whom the fluid recurred very fast, like this one on the arrow, did badly. Those in whom the fluid didn't come back after the first 3 injections, they did much better. The other important thing that came out is not only is it important to delay the recurrences, but it's also important to decrease the fluctuation. So in the Hock and Harrier study, what they showed was patients who had minimal fluctuation had the best visual acuity. They had patients, on the other hand, who had, you can see over here, this is almost 10 letters improvement, while those who had very high fluctuation in fluid, they had very poor vision improvement. Of all the fluids, subretinal fluid seems to be the one which is least damaging, but they're all damaging in their own way. The other important thing is that intraretinal fluid is very damaging, especially if it involves the fovea. These are the points we take into consideration for deciding how to manage. And this was a study which evaluated the role of fluid by taking those patients who had maximum fluid versus those who had less fluid. And they saw those who had less fluid at baseline, they were more likely to have better outcomes, whereas those who had more fluid did not do as well. Treatment protocols vary from monthly to 2-monthly to PRN to treat and extend, but what we've learned is that if you're going to use PRN treatment, you need very stringent guidelines for retreatment, including small loss of BCVA, any fluid, any increase in thickness, any new macular hemorrhage. On the other hand, the other alternative is a treat and extend regime, where you give treatment till the patient dries, and then you increase the intervals between the treatments. Now what happens is, you keep on increasing every 2 to 4 weeks till you reach a maximum of 12 weeks with ranibizumab or 16 weeks with aflibercept. Other studies have done the same thing, and they showed that the number of injections can be decreased. My opinion is that if you've got a patient who is one-eyed or a patient who is stable but not drying, these patients are good for treat and extend. But patients who have both the eyes, the cheaper option is, in patients who become dry, is a PRN treatment. As far as efficacy is concerned, we know that ranibizumab is effective for type 2. For type 1, aflibercept is better than ranibizumab. But in terms of drying of the fluid, brolucizumab is probably the best. As you can see here, brolucizumab dries all types of fluid faster than the other drugs. Now, which is optimal? Well, they are all safe, but we do know that with brolucizumab, there is a 1 in 200 risk of intraocular inflammation and 1 in 400 risk of inflammatory occlusions occurring also. So how do we actually treat a patient? Now, you have a patient, you've given the first 3 injections, it's become dry. You have 2 options. Either you do treat and extend, or you do a PRN treatment. If the patient was one-eyed, I would prefer treat and extend. If the patient is not one-eyed, I would prefer to take on PRN treatment. Keep on following up monthly. We call it wait and extend, monitor and extend. On the other hand, if the patient, after 3 injections, still has some fluid, you continue to give injections for the next 3 months. If you find that the amount of fluid has become stable, now this is the patient you can take into a treat and extend regime. Increase the intervals and see what is the maximum duration that the patient tolerates. Now, when do you switch drugs? If the patient is getting ranibizumab and he needs the injection more than once in 7 weeks, consider a switch to aflibercept. If he's on aflibercept already, needs aflibercept more than once in 7 weeks, consider a switch to brolucizumab. Again, a patient who is stable but not dry and he's getting monthly ranibizumab, consider a switch to aflibercept. On the other hand, if with aflibercept he's stable but not dry, consider a switch again to brolucizumab. Now, what do you do if you put the patient on brolucizumab and there's still some fluid at 4 weeks? Now give him aflibercept. So switch between brolucizumab and aflibercept. The good thing is, ultimately, regardless of what injection you give, all the patients had the same visual outcome in this study, which compared all the 3 drugs, ranibizumab, aflibercept, and bevacizumab. So ultimately, the outcomes were not different, nor was the number of injections. But what was different was that the more the number of injections, the more time the injections was given, the better the visual outcome. So ultimately, persistence is the key. Giving injections regularly is the key to better results. And this study, called the FIDO study, showed us just this. Even with ranibizumab, they got 40% patients over 7 years who had a vision of better than 20/40. So if you persist regularly with the treatments, the patient gets good vision. So ultimately, to conclude, ladies and gentlemen, the basic principles of AMD management are no tolerance for fluid. But now, if intraretinal fluid is completely unresponsive, then you may tolerate it and maintain it. You don't let it increase. Subretinal fluid of up to 100 micron, you may tolerate. It's less toxic. Sub-RPE fluid does not respond to ranibizumab and responds very partially to aflibercept, so don't run after sub-RPE fluid. But any increase in fluid is not to be tolerated. Ultimately, aggressive treatment is the key. Monthly follow-up, not monthly treatment, but monthly follow-up till the lesion heals, and then 3 monthly lifelong is the key to better response. Greater the number of injections, more intensive and longer the follow-up, better the visual outcome. Initial PRN treatment can be converted later to treat and extend regime once you know how often the patient is needing the treatment. But you need a high index of suspicion for retreatment. Any slight deterioration must be treated. Ladies and gentlemen, Eternal vigil is the price that we pay for maintaining vision in patients with CNV, but with that vigil, we can hope to keep many of these patients who are old and for whom the most important thing is reading, and we can keep them going for a long, long time. Thank you very much, ladies and gentlemen.
I think it was a wonderful lecture, especially for people like me, who handle only entry segment people, and to understand how this patient actually work with the anti-VEGF treatment. Many of have no idea, but you nicely described and when to change the drugs, when to observe these patients. I think we all understand key is the very critical is the regular follow-up these patients and decide what is to be done.
Yeah, and that's where lots of people actually they want to show that we are not giving too many injections. So they'll say come after 3 months.
Yeah.
Actually, that one visit can make the difference between getting good vision and bad vision.
Yeah.
So
Thank
it's
you.
very important to do
Thank you, Dinesh, for a terrific highlighting the very common problem of a day.